and thank you so much for joining us for another mini med school seminar hosted by the Cardiovascular Research Foundation and the Women's Heart Health Initiative. I am thrilled to talk about something that right now we are living through a pandemic, but there are actually health epidemics that are going on in the country that have been going on for decades that we should talk about and that affect a lot of our patients, a lot of your family members, a lot of your loved ones. I'm thrilled to have Dr. Hannah Rosenblum, who is one of our cardiology fellows at Columbia University Medical Center, who is also going to specialize in heart failure, as well as Shayne Robinson, who is one of our registered dietitians, and at NewYork-Presbyterian Medical Center, who is also going to be sharing some insights about things you can do proactively to take control of any of these conditions that we're going to talk about. So, two things that we need to talk about are heart failure and diabetes. You know that diabetes is the topic that we love to talk about a lot. So there's a lot of information on our website and you are welcome to look at it. But we're trying to look at the interconnection between these two conditions. So heart failure and diabetes. And now there's been, over the past couple years, a lot of data that comes out showing that some drugs work for both conditions simultaneously. So I'm going to start out by just presenting an introduction on both, and it's going to feel a little bit choppy because I'm going to talk about heart failure first because I think we're cardiology driven. So let's talk about heart failure, but then let's also talk about why is diabetes such a major driver for some of these chronic heart failure patients that we have. So I'm going to introduce our first two topics, heart failure and diabetes, two epidemics that we're living through even during this pandemic. Heart disease, again, hopefully you know this already, but heart disease is the #1 killer of both men and women in the United States. 1 in 3 Americans actually has heart disease. And although the rates of death from heart disease has declined over the past 5 years, or past, 5+ years, the rates of heart failure are actually rising. So there's currently about 6.5 million Americans that are living with heart failure. And it's the leading cause of hospitalization in people who are over the age of 65. And this is a scary statistic because I'm like kind of aging myself now, but if of all adults age 40 and above, 1 in 5 will develop heart failure sometime in their lifetime. The number of Americans that are living with heart failure has risen by 800,000 over the past 5 years. And part of it is because we have a lot better therapies in cardiology to have patients with heart disease live longer, and that's a great thing. And then for other reasons as well, life expectancy is increasing. But the number is expected to rise even more. By 2030, they estimate that 8 million people will be living with heart failure. So what exactly is heart failure? Because I think it's a very vague term, and I think it also gets confused with a lot of other terms that we use that you may hear friends and family talk about. So heart failure is the same thing as cardiomyopathy, is the same thing as congestive heart failure. It's all describing the same clinical entity. So if you look at what is the actual clinical definition, it's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or the ejection of blood. So the ventricles are the two bottom chambers of the heart. The right ventricle is responsible for pumping blood to your lungs. The left ventricle is responsible for pumping blood to the rest of your body. So it can be either a pump problem or a filling problem, and it can affect either the right side or the left side. Systolic means it's a pump problem. Diastolic means it's a filling problem. So if you have chronic diastolic heart failure, for example, is not something that we typically think of, but it basically means that the pumping function of the heart is totally normal. But because the heart has become stiff for whatever reason, it's a filling problem. And so the blood cannot fill into the left ventricle or the right ventricle as much as it should be able to. And therefore you have a backup of blood. And so what do we talk about? So ejection fraction, what is normal pump function? What's not normal pump function? So a normal ejection fraction is anywhere between 50 and 70. Mildly reduced, moderately reduced. You can see the numbers here. Anything that's less than 35% is considered severely reduced ejection fraction or severely reduced pump function of the heart. And there are additional therapies on top of the medications that we use for all types of heart failure or all types of systolic heart failure that can be indicated in people with a severely reduced ejection fraction. So, for example, implantable cardioverter defibrillators, which are ICDs, or even resynchronization therapy in select patients, which is called CRT. But you may hear some of these phrases when talking to or about patients with heart failure. And then, like, that wasn't complicated enough. So there can be systolic, diastolic, right-sided, left-sided. But then why does a person have heart failure? So I said that there's a lot of different causes, but one of the most common, and particularly in patients with type 2 diabetes, is ischemic cardiomyopathy or ischemic heart failure. And what that can mean is that either a person has had a prior heart attack and they have scar there, which means that muscle, that part of the heart muscle, just like this black area here, that part of the heart muscle, because there's this blockage in yellow, is dead. So anything that is supplied by the blood supply after that point, if it's a true heart attack, is now scar. And so even opening up that blockage is not going to help that person's heart function. Or there can be coronary artery disease that's either in a very significant place or is like multivessel, which can lead to heart failure because the person has a lot of blockages and they're not getting enough blood flow to the heart at any given time. That is something that is reversible, that you can fix the blockages and hopefully the heart function gets better. And then there's this very, very long list, and I'm sure I've left off some, of non-ischemic cardiomyopathy. So what that means is cardiomyopathies or heart failure that's due to something other than a blockage in the arteries. So that can be hypertension, it can be idiopathic, which means we have no idea why it happened, myocarditis, which is maybe a viral thing, but usually an inflammatory process of the heart muscle itself. It can be due to congenital heart disease, which people are born with, valvular heart diseases, which hopefully can get treated, pregnancy, which is, or peripartum. So anything that is a couple months before or after a person gives birth, this is something that you need to think about. Thyroid diseases, stress-induced, or also known as broken heart syndrome, and then infiltrative diseases. And there's even some lung diseases that can be so severe that they actually affect the function of a person's heart. So, like I said, the definition of heart failure is very complicated. It means that a person is presenting with symptoms or signs of heart failure. So what are some of these signs and symptoms? Well, they can include shortness of breath with exertion. So if you look here, this is a chest x-ray, and you are not expected to know how to read it, but it's a very, what we would call wet chest x-ray. It's basically the heart is so overloaded with blood and it's not able to push it forward, either because of a pump problem or a filling problem, that it sort of backs up into the lungs. And it looks like, it looks like this on a chest x-ray, and it also feels like all of these things when patients present with it. So basically it's a backup of blood into the lungs, which causes shortness of breath with exertion. It can present as a chronic cough. Going along with those lines, waking up in the middle of the night, gasping for air, or needing to sleep on more and more pillows because you need to feel elevated when you're sleeping. Those are all signs and symptoms of pulmonary edema or just overflow into the lungs. Also, like a very quick weight gain. If that's something that you're noticing, especially if you have this kind of thing where you have pitting edema in your legs or in your feet, inability to lie flat, like I already mentioned, or it can be more vague than that. Just abdominal distension, feeling like you're feeling really bloated or losing your appetite. And that can be because it's more right-sided heart failure, where that leads to fluid buildup in the abdomen as opposed to in the lungs. or just feeling tired, palpitations, things like that, associated symptoms. So it's obviously a very broad range of signs and symptoms that can be suspicious for heart failure. And then based on, if you do have somebody who is diagnosed with heart failure, based on their functional class, that kind of gauges not only their prognosis, but also their treatment. And so stage 1 is no limitation to exercise whatsoever. So there's something wrong on their echocardiogram, or somebody's diagnosed them with something, but they have no functional limitations whatsoever. And there's a lot of patients who live in this stage, so it's a good thing. Stage 2 would be slight limitations. So ordinary activity can cause symptoms. That means taking a long walk, you might get short of breath earlier than you would have before your diagnosis. Marked limitation means that less than ordinary activity. So doing just normal activities, you can't even complete those. These are people who get up and walk 20 feet to the bathroom and feel short of breath. And then stage 4 would be symptoms at rest. These are very advanced patients. Luckily, we don't see in the community, but also in clinical practice, most cardiologists see stage 1 and 2 heart failure patients, maybe some stage 3. At the stages of 3 and 4, those are usually the patients that need to start seeing a heart failure cardiologist, like Dr. Rosenblum. And so what are some of the treatments? Well, Dr. Rosenblum's going to talk about some of them, but in general, you want to treat the underlying cause. So if it's because of a blockage in the arteries, well, that's great. I mean, it's not great, but it's kind of great from a heart failure perspective, because you can fix them and hopefully patients will get better. CABG, or CABG, stands for coronary artery bypass grafting. So if they have a lot of blockages, they need bypass surgery. That's also an option. Valve replacement, either with interventional therapies like this or with surgical valve replacement. But there's a lot of options that are reversible. So people should always be worked up for those first. Lifestyle changes, which I think I have a slide on, but I'm kind of going to leave to our nutritionist and dietitian, who can talk about some of the dietary issues related to a heart failure diagnosis. There's medications, and then if it's really advanced, like stages NYHA class 3 to 4 heart failure, then you need to start seeing a heart failure specialist to talk about advanced therapies. So in general, if somebody is concerned about preventing heart failure hospitalizations, or preventing decompensation of their heart failure, lifestyle modifications are always the first choice. And that's with everything in life. The things you can do at home are probably the most beneficial, in addition to the medications. So check your weight daily. You want to make sure that if you gain more than 2 pounds in a day or 5 pounds in a week, that means that it's probably water retention from a heart failure exacerbation, and you should call your doctor. You want to drink less than 1.5 liters of liquid, any liquid, all day. Limit your sodium to 1.5 grams per day, which is really difficult. And this is the more stringent definition. You can also limit it to less than 2 grams per day. But in general, like almost all of the processed things that we eat have a high sodium content. Canned foods, breads, rolls, cold cuts, cured meats, cheese, soup, seafood, olives. Like there's so many things that taste delicious that seem like they're healthy. Like if I was having a cheese plate of meat and cheese and olives, like that may actually seem like a really fancy, nice meal, but it's loaded with sodium. Avoid smoking, alcohol, caffeine, high stress. Obviously, physical activity is very important. And then I left off the COVID shot because I made this slide before COVID. But get your COVID shot, get your COVID booster, get all of your family boosted and vaxxed, and get the flu shot. And if you're over a certain age, get your pneumonia vaccine as well. So I'm going to shift gears and I'm going to talk about diabetes. I talked about why, because I'm a cardiologist, heart failure is a huge problem. 2030 can have 8 million people affected with heart failure. So let's talk about pre-diabetes, diabetes. It's so much bigger. Um, Pre-diabetes affects 84.1 million people in the United States. This is old data, so it's probably even higher than that, but it's more than a third of the US population, and 90% of them don't know that they have it. Why? Because it's largely asymptomatic and you need a blood test to diagnose it. People who have actual diabetes, which is hemoglobin A1C, the blood test I was talking about, of more than 6.5%, there's 30.3 million people in the US, 10%, almost 10%, 9.4% of the US population, and 7.2 million people are undiagnosed. So that's even scarier, because I'm going to tell you why diabetes is such a bad thing, especially when it comes to heart failure, in just a second. So by 2030, the prevalence of diabetes in the US is expected to rise to almost 55 million Americans. So I was talking about how heart failure is such a huge issue. By 2030, we're looking at 8 million people with with heart failure in the US. Think about diabetes, 55 million Americans. 1.5 million Americans are diagnosed with diabetes every single year, and nearly 10% of all pregnancies in the US are affected by gestational diabetes, which means that that woman is at a 7 times increased risk, at least, of developing diabetes in her lifetime. And why is it that diabetes is such an epidemic? So there's another epidemic that I'm not here to talk about specifically, but obesity is probably the largest epidemic in the US. But you can see here, and this is obviously old data, it's more than 10 years old, but you can see here the rates of obesity have risen. So if you look from 1994 to 2010, have risen. This whole map is like orange or red. And coinciding with that is B here is diabetes. Type 2 diabetes has also risen to the same extent. So the diabetes epidemic is absolutely linked to the obesity epidemic in the United States. And what is it exactly that is such a huge issue with all these patients, 55 million Americans living with diabetes? Well, it can lead to heart attacks. It can lead to chronic heart failure, like I've alluded to. It can lead to strokes. It can lead to lower extremity or like leg ulcers and infections, which then can lead to amputations. It can lead to chronic kidney disease, which leaves some people on dialysis. It can lead to blindness and a lot of other things, obviously, that I must be missing. It's a very costly disease as well, and I won't read through it, but billions, we're talking hundreds of billions. So when when healthcare professionals or when patients think about diabetes and they think about their cardiovascular risk, it's mostly due to the risk of developing plaque in the arteries, right? And so um, I think people know that diabetes is one of the risk factors for developing coronary artery disease or plaque in the arteries of the heart, which also means you have plaque in arteries of other organs as well, right? So the kidneys, the brain. Um, but this is not the only thing. So, yes, this can lead to accelerated atherosclerosis or hardening of the arteries, a lot of plaque. And this can obviously lead to some of the heart attack or coronary artery disease issues that diabetic patients have. But if you look at the risk of excess events, so patients who have type 2 diabetes versus patients who do not, what is their risk of excess events? And heart failure, CHF or congestive heart failure is actually the leading cause of excess events per 1,000 patient years. So that means that diabetic patients are most at risk for heart failure, and that precedes heart attacks, PAD or PVD, which is leg disease, stroke, heart attacks again, death, but more than any other condition. And it's also one of the earliest occurring cardiovascular complications in type 2 diabetes. So 14% of patients with diabetes who had some manifestation of heart disease, it was actually the number 2 leading cause. The first was actually PAD, which was surprising to me. It means that people are obviously being underdiagnosed for their their leg disease, but that can also include carotid disease and additional peripheral vascular conditions. But heart failure is one of the earliest manifestations of cardiovascular disease in diabetic patients. And this is something that Dr. Rosenblum is going to touch on some more. But if you look at all of the effects of type 2 diabetes on the heart, there is a lot of stuff that you don't need to understand, but it affects the kidneys. It causes hypertension, which is high blood pressure. It causes an increase in fluid within the body, increases arterial stiffness, which leads to the atherosclerosis, and activates all these mechanisms of other bad cardiovascular effects. And it can lead to this entity that's suggested or called diabetic cardiomyopathy. It's just another phrase for all of the things that happen in patients with type 2 diabetes that can lead to some form of another of heart failure. And like I described, there are almost like 8 different combinations of just general phrases to describe the type of heart failure that people can develop. So either structural heart disease or symptomatic heart failure. 68% of patients within a diagnosis of type 2 diabetes within 5 years has had some sort of echo evidence or a sonogram evidence of having either a pumping problem or a filling problem. And what that basically leads to is that 1 in 2 patients with type 2 diabetes can develop heart failure in their lifetime. And like we talked about before, heart failure is a progressive disease that leads to worsening myocardial function and recurrent hospitalization. So this graph is something that a lot of doctors have seen, but just for people who have not seen this themselves, when you have heart failure, whether it's symptomatic or not, the first time that you require a hospitalization, you have this acute decompensation. That's that dip in the first dip. And then no matter how much better you get, you'll never be as good as you were when you started. And so every time that a person has an exacerbation for heart failure, things will get worse and worse, not only with their heart function, but also with their symptoms. And the reason why I want to bring it back to heart failure is that obviously it is the most frequent diagnosis that's associated with 30-day readmission. That means if somebody is hospitalized with heart failure, it is the number one diagnosis that brings people back to the hospital within 30 days. And it's like a huge driver of cost for the country, but for hospital systems and obviously patients. Nobody likes to be rehospitalized a week after they've been in the hospital. And so this is a very major issue, and I'm trying to bridge together the diabetes and heart failure aspects here. So because it's become so apparent for several years now that diabetes is such a driver for heart failure and for heart failure exacerbation. If a patient has heart disease and then develops diabetes, they'll do worse. If they have diabetes and then they're much more likely to develop heart failure or heart disease and then will again do worse. So this is, you probably can't read this and you absolutely don't need to, but this is something that gets put out every year by the American Diabetes Association. And in 2019, for the first time ever, the ADA, or the American Diabetes Association, put out guidelines that say that after metformin and lifestyle changes, that a person's drug choices or medication choices should be driven by their risk for heart disease. So if they are at risk for heart failure, there's a certain pathway. And if they're at risk for more, ASCVD stands for atherosclerotic heart disease. And so it's more if they're at risk for stroke or heart attacks. But this is the first time that the standards of diabetes care put out by the American Diabetes Association was endorsed by the ACC and the AHA, which are the big cardiology societies in the country. And so I'm going to hand this over now to Dr. Rosenblum, who is one of our future heart failure cardiologists, who can talk more about the medication therapies, but then also some of the other heart failure aspects of these two conditions. So thank you very much.
Hi, everyone. I'm Hannah Rosenblum. I'm one of the general cardiology fellows at Columbia. And as Dr. Jhalani mentioned, I'm going to be talking today about the intersection between diabetes and heart failure, and some of the different medications that we use in both of these conditions. So as Dr. Jhalani started telling us about, patients with diabetes have a very much increased risk for developing heart failure. In fact, data from the Framingham Heart Study, which is a large study in a community-based setting, indicated that diabetes increases the risk of heart failure up to 2 times in men and up to 5 times in women. Also importantly, up to 44% of patients that are hospitalized for heart failure have diabetes. So the intersection between these two diseases is really very important and very notable. Diabetes can lead to heart disease in 2 different ways. The first and most commonly known is the association between diabetes and coronary artery disease. As Dr. Jhalani talked about, diabetes can affect the vasculature and lead to plaque buildup in the heart. And this leads to increased risk of heart attacks in people with diabetes. People with diabetes are also at risk for heart attacks because of how diabetes affects the blood vessels. And in general, people with diabetes also have a higher amount of LDL, or as we know, bad cholesterol, which also increases the risk for coronary artery disease and for heart attacks. However, diabetes can also lead to heart failure without causing heart attacks as well. Heart failure in diabetic patients, which is also called diabetic cardiomyopathy, is caused by changes in the heart structure and function without coronary artery disease. So there's 2 types of heart failure that can be caused by diabetes. When diabetes affects the heart's ability to relax and fill, this is caused diastolic heart failure, or as we see here with a thick ventricle, and is called heart failure with preserved ejection fraction. And when diabetes causes problems with the heart's ability to pump blood, this is referred to as systolic heart failure, or heart failure with reduced ejection fraction. And the treatment for each of these conditions is dependent on the initial problem with the heart. So whether the problem is with pumping or with filling. So this is a busy slide, but I'm going to go through some of the common medications that we use for heart failure. There are, if you know someone with heart failure, they may be on 1 or more of these medications, and these medications have really been shown to improve outcomes in patients with heart failure. So beta blockers, which some commonly known beta blockers are metoprolol and carvedilol, are used to block the sympathetic nervous system. And the sympathetic nervous system is our fight or flight response, and is revved up in heart failure. Beta blockers lower the heart rate and improve the pumping function of the heart. They also slow the progression of symptoms for patients with heart failure with reduced ejection fraction, and have been shown to improve life expectancy and decrease heart failure hospitalizations. ACE inhibitors are another large group of medications. Some of the more commonly used ACE inhibitors are lisinopril and ramipril. These are also used in heart failure with reduced ejection fraction. Angiotensin receptor blockers, or ARBs, that are the more common version of these is losartan or valsartan, also work in heart failure with reduced ejection fraction. And the ACE inhibitors and the ARBs works in similar ways. They both work by blocking hormones that are increased in heart failure, and they improved heart pumping function in heart failure with reduced ejection fraction. And similar to beta blockers, they improve life expectancy and decrease heart failure hospitalizations. ARNI, or sacubitril valsartan, or Entresto, is a new class of medication that includes both an ARB and a neprilysin enzyme inhibitor, sacubitril. Sacubitril allows the body to get rid of salt and water, and unlike the previous medications, which have only been shown benefit in heart failure with reduced ejection fraction, ARNI actually is now approved for some patients with heart failure with preserved ejection fraction, so that's stiffer heart. Mineralocorticoid receptor antagonists, which more commonly known as spironolactone or eplerenone, can be used both in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And these are a class of medications that can be added to some of these other treatments and work both in both types of heart failures. Diuretics do not improve more life expectancy, but they can really help with symptoms in heart failure. So diuretics are the class of medication that gets rid of extra fluid that builds up in the body. You may have heard of furosemide or torsemide, or Lasix is also furosemide. And these medications work by getting rid of extra salt and extra water. They're used in both types of heart failure and are really important for managing the symptoms of heart failure. SGLT2 inhibitors are a new class of medications, which we'll talk about more in the next few slides. But these were originally developed actually for the management of diabetes, but several studies have now shown that they've been beneficial in both heart failure with reduced and preserved ejection fraction. I'm going to shift gears a little bit and talk now about some of the mainstay treatments for diabetes. So our first class of medication is metformin, and that's really the backbone of therapy for type 2 diabetes. This medication works by helping the body decrease glucose production and increase the sensitivity of the body to its own insulin. Sulfonylureas, such as glyburide or glipizide, help the body secrete more insulin. Thiazolidinediones, such as rosiglitazone or pioglitazone, make the body's tissues more sensitive to insulin. DPP-4 inhibitors help reduce blood sugar levels. GLP-1 receptor agonists are injectable medications that slow digestion and help lower blood sugar levels. And there's some data to suggest that they reduce the risk of heart attack and stroke. These SGLT2 inhibitors, as I mentioned previously, dapagliflozin and empagliflozin, are some of the newer medications that we can use for diabetes. And they not only help increase blood sugar control for patients with diabetes, but they also have beneficial effects on cardiovascular outcomes. And the way that these medications work is that they help the body get rid of glucose by excreting it in the urine. And as I mentioned, they also reduce the risk of heart attack and stroke and also work in heart failure. And lastly, we have insulin that is the injectable medication that patients can use for diabetes, and that works to directly replace the insulin that is naturally made in the body. So as I mentioned, SGLT2 inhibitors are this new class of medications that were initially developed for the treatment of diabetes, and that work by blocking glucose reabsorption by the kidneys and reduce circulating levels of blood sugar. SGLT2 inhibitors are effective for improving glycemic control in patients with diabetes. And in the initial SGLT2 inhibitor studies in diabetics, there were signals that these drugs could be beneficial for reducing cardiovascular events, including heart failure admissions. This led to several studies investing SGLT2 inhibitors in patients with diabetes, and then finally in patients with heart failure without diabetes. So there are multiple proposed mechanisms for why SGLT2 inhibitors have beneficial cardiovascular effects beyond the control of blood sugar. So SGLT2 inhibitors, because they allow the kidney to get rid of sugar, also removes fluid from the body. This is similar to how diuretics work in heart failure, but our more traditional diuretics, such as Lasix or furosemide or torsemide, work by getting rid of salt and water. SGLT2 inhibitors work by getting rid of sugar and water. So importantly, when the SGLT2 inhibitors are given to patients with diabetes and heart failure, these medications don't lead to the same increase in that sympathetic nervous system, which is the fight or flight nervous system that we see with more traditional diuretic therapies. There's also evidence that SGLT2 inhibitors lead to decreased activation of hormones in heart failure, which can explain some of the benefits on the kidneys and heart of this drug class. And SGLT2 inhibitors also stabilize kidney function over time and prevent progression of kidney disease. In terms of the heart, so this slide is complicated, but I'm going to sum it up in a pretty understandable way. The diuretic effect, which is that removal of fluid that the SGLT2 inhibitors have on the body, leads to decreased wall stress on the heart. This is particularly important in patients with HFpEF, or that stiff heart version of heart failure. As mentioned previously, the diuretic effect of the SGLT2 inhibitors does not cause that increased sympathetic system activation that we see with traditional diuretic therapies. SGLT2 inhibitors also work on the blood vessels. They decrease stiffness in the large arteries and decrease blood pressure, both of which of these have beneficial effects on heart function. And SGLT2 inhibitors also increase the production of ketones, which are more energy efficient than what the heart typically uses, and may have a reduced risk of heart failure by enhancing the cardiac efficiency and contractile function. There is also data that SGLT2 inhibitors can reduce the left ventricular mass and reverse cardiac dysfunction in patients with diabetes and coronary artery disease. All of these things lead to improved relaxation and improved cardiac function. SGLT2 inhibitors have also shown to reduce circulating markers of inflammation, which can otherwise lead to cardiac stiffness and problems with relaxation. So to summarize, SGLT2 inhibitors really, that were developed to help patients with diabetes have now been shown to be very beneficial also for patients with heart failure, even without diabetes. And now I'm going to turn it over to Shayne Robinson, who is going to talk a little bit more about the nutritional aspects of heart failure and diabetes.
Hi, thank you so much. My name is Shayne Robinson. I am a registered dietitian working with heart failure patients. And today I am going to talk about eating for overall health, for heart failure, and for diabetes. I'm going to start by talking about a balanced diet. I'll move on to talking about sodium restrictions. And I'm not going to talk that much about fluid restrictions because those are quite individualized, but I do want to acknowledge that that is part of the management of heart failure. And so a healthy diet is a balance of the right foods in the right portions. And there are countless benefits to a healthy diet. A healthy diet is actually one of the most basic ways we care for our bodies. When we follow a healthy diet, we tend to feel better physically and emotionally and have more energy. A healthy diet helps manage chronic conditions such as diabetes, heart failure, high blood pressure, high cholesterol. It can also help prevent the development of new health problems. It ensures we're getting enough vitamins and minerals from our food. It helps keep us regular, and it also helps us feel full for longer. So a healthy diet really means choosing foods that promote health and includes a balance of proteins, starches, non-starchy vegetables, fruits, and healthy fats. Now, there's no one single correct way to eat. Everybody's body is different. Their nutrient needs are different. Their food preferences and cultural food choices are different. But there is a way to explain a healthy diet as a plate diagram. And so we want to start by building a healthy plate. When we build a healthy plate, we divide the plate into 4 even sections. And then we take 2 of those sections, or half of the plate, as non-starchy vegetables. A quarter of the plate is protein. And then the last quarter of the plate is going to be some sort of starch. So to start off, protein is the most important to all parts of the body. It's the building blocks of our organs, muscles, and bones. Eating enough protein ensures that we help maintain our muscles. And I do have to remind us all that a heart is a muscle. Proteins can come from both plant foods and animal foods. The plant proteins do tend to be less expensive and higher in fiber than the animal foods. And our best sources of protein are things like beans and lentils, nuts and seeds, tofu or soy, low sodium cheeses, poultry, eggs, fish, seafoods, and milks and yogurt. The things we want to limit are the red meats, things like beef, pork, and lamb. And we also want to limit processed meats. These things are really high in sodium, and these are things like your deli meats, cold cut sausage, pastrami, bacon, hot dogs, salami. The next section of the plate that we're going to talk about are the starches. And the starches provide the body with energy. This energy comes from the carbohydrate and sugar in these foods. Now, the starches can increase blood sugar levels. So if you're diabetic or even pre-diabetic, you really want to make sure that you choose the right portion of starch for your body. And I encourage you to choose most, if not all, of your starches as whole grains. What this means is that the starch is going to have some fiber in it. Now, starches can come from the grains, but they also can come from fruits and the starchy vegetables. And so if you look at our list of starches, I've divided it into two sections. We've got both the grains and the starchy vegetables. When we talk about grains, I already said we want to choose things that are whole grains. So if you're buying any sort of bread, it should say 100% whole wheat. If you're choosing a cereal or a rice, you would always want to choose the one with fiber. So a good example would be you would choose brown rice over white rice. And now where it sometimes gets confusing is that some of the vegetables that are very starchy also count in the starch category. So if you are having a meal with some rice, you would not be able to count your corn or your peas as a vegetable. Those are also going to be considered a starch. And then there's the section of non-starchy vegetables. And what I want you to always keep in mind is the non-starchy vegetables should be about 50% of your plate. The non-starchy vegetables are a great source of fiber. If you're trying to lose weight, they're great because they tend to be low in calories. And since they're high in fiber, they really make you feel full. They also provide lots of vitamins and minerals. You want to choose a variety of different colors in your vegetables. And you want to eat, you can eat them raw or cooked. I would recommend you choose fresh or frozen varieties. You do have to be really cautious when choosing canned vegetables, as unless there's specifically no salt added or low in sodium, they tend to be very high in salt. And so here are some examples of non-starchy vegetables. And what I want to remind everybody is that adding a vegetable to your diet does not have to be fancy. On a summer night when I do not feel like cooking and I am serving a meal and I'm not going to sit there and steam a vegetable or even do any work to cut it, I take one of those bags of pre-peeled, pre-cut carrots and I open the bag and put it on the table and say, there, at least we have a vegetable with the meal. So I want you to keep in mind that the vegetables served raw, just plain, still counts and is a great way to add some non-starchy vegetables into your diet. And then we have the fruits. Fruits are a great source of fiber, potassium, and vitamins. They do affect blood sugar levels, so we need to exercise portion control, especially if you're diabetic or trying to lose weight. And I would encourage people to eat whole fruits, either fresh or frozen, in place of fruit juices. Fruit juices tend to be quite high in sugar and do not have the fiber that the whole fruits have. And here are examples of fruits. You want to choose seasonal when you can, because seasonal fruits tend to be the best quality. And then there's the healthy fats. And we really include our healthy fats at all the meals. When we talk about healthy fats, we're mostly talking about fats from plant sources. And they have lots of benefits. They may lower the risk of some disease. They do provide the body with some of the nutrients it needs, but they also help the body absorb other nutrients. And they also add flavor to food. And so here are some examples of healthy fats. We mainly choose olive oil, but canola oil is acceptable too. Avocado, nuts, seeds, olives are all great sources of our healthy fats. And so too much sodium can cause a lot of different problems, but it's especially problematic for our heart failure patients. And so I'm going to move now to talking about limiting sodium in the diet. So let's first talk about the guidelines of how much sodium we need. So the recommendation of the American Heart Association is to eat less than 1,500 milligrams of sodium per day. The reality is that the average American eats more than double that. They eat more than 3,400 milligrams of sodium a day. Actually, 70% of the sodium in our diets comes from processed foods, packaged foods, and restaurant foods, with only approximately 11% of sodium coming from the salt shaker. But what we have to keep in mind is if we want to keep the diet under this 1,500 milligrams of sodium, there's really no room for added salt. 1 teaspoon of salt provides 2,300 milligrams of sodium a day, way more than we're allowed on that 1,500 milligram recommendation. And so since we know that most of the sodium in our diet does not come from the salt shaker, it's very important to know how to read the nutrition facts label. And so the first place we look on the nutrition facts label is the serving size. The serving size tells us the amount of food that the list below provides. So if our serving size is 2/3 of a cup, and if you look at our label, it says 160 milligrams of sodium. So that means that there's 160 milligrams of sodium in that 2/3 of a cup. If you double the portion, then you have double the amount of sodium. Now, the sodium is listed in a few different ways. It's listed in milligrams and it's also listed in percentage. So the percentages are good if you're comparing one food to the other. And this tells you what percent of the daily value is in this food. What you really need to keep in mind is that this is not based on this recommendation of 1,500 milligrams. This is actually based on the recommendation for the general public, not specifically the recommendation for heart failure patients. So if you add up everything that you ate over the course of the day and got to 100%, you would be consuming more than the 1,500 milligrams of sodium. So if you're looking at this label and the number is anywhere between 0 and 3, that's a low sodium food. Anything above 13% is going to be a high sodium food. It's also important to know the nutrition facts label terminology, because this can be a little tricky. So if something says it's low sodium or sodium free, no salt added or unsalted, that means that it naturally contains less than 5 milligrams of sodium per serving, and they have not added any salt to the product. If it says it's very low sodium, then it has less than 35 milligrams of sodium per serving. Again, still a low sodium product. These are good terms. And then if it just says low sodium, it's less than 140 milligrams of sodium per serving. Where it gets trickier, there are other terms that indicate that the food is lower in sodium, but not necessarily low. So some foods say that they are reduced sodium, and that means they have at least 25% sodium less than the usual sodium. And so you see this a lot on cold cuts. Problem is, if you're starting with a serving of cold cuts that has 500 milligrams of sodium in 2 ounces, and you reduce it by 25%, you still end up with a high sodium food. And so you have to really be careful and look at not just the terminology, but the milligrams of sodium on some of these foods. So how do we lower the sodium in our diet? Well, one of the best ways is to cook at home. If you're cooking at home, you can use fresh unprocessed ingredients, and you have more control over what goes into your food. What you want to be careful about are things that are pre-prepared, things like instant and packaged products such as sauces, rice mixes. These tend to have a lot of sodium added to them, and this is where reading that nutrition facts label really comes into play. You also want to use seasons to boost your flavor of your food without adding any sodium. So you would want to add acidic ingredients such as citrus, such as lemon, lime, orange, or maybe use the zest of some citrus or vinegars to brighten dishes. Garlic and onions can add some depth and salt-free flavor to the dishes. And then herbs and spices also add depth. You can use fresh herbs. You also can use dry herbs. I encourage you to use fresh dried herbs as they do lose taste over time. And so I always encourage people to buy them in the smallest quantity possible. They say that herbs actually don't last more than a year. So in summary, a balanced low sodium diet can help manage heart failure and diabetes. We always want to build a healthy, balanced plate, aim for at least 50% of the plate as non-starchy vegetables. And you want to balance your sodium intake by being sodium aware, reading labels, cooking at home, and limiting or avoiding processed foods.
Thank you so much, Shayne. That was amazing information. I'm so glad that you shared. I learned so much from that as well, because I think as physicians we often don't know a lot of the nutrition facts that go into, or the nutrition truths that go into what we tell our patients. So I'm just wondering if you could summarize into 3 bullet points. What would be the most important things that you could tell somebody who actually is living with both type 2 diabetes and heart failure?
Sure, of course. I think, if we look at like the most important things, I want you to always think of that my plate model of the 50% of plate as non-starchy vegetables and really aiming for a good balance. The next thing I would say is to keep the sodium intake under the 1500 milligrams, you really want to take a look at food labels. And then I would say the last thing is really to limit restaurant foods, takeout, fast foods, anything eaten outside the home, even foods prepared by others, tend to be very high in sodium. And so I think those are my top 3. But then I would have to add to that, if you're struggling, you should consult a registered dietitian. A registered dietitian is trained to help you find a meal plan that works for you.
Yeah, I think that's so important, is that a lot of people don't realize that that's a part of their sort of care team, right? Like we talk about care
Absolutely.
team when we talk about heart failure, when we talk about diabetes, people should have a primary care doctor, a cardiologist, an endocrinologist, or a primary care. Like we talk about so many people that are involved in people's care, but I think the nutrition and dietitian aspect of this is like so pivotal
Yeah.
to preventing a lot of this. And that's sort of the goal of this program, is to try to empower people on what they can do at home. And I think you've given them so much invaluable information.
Yeah, and that's where we started the program. The first thing I said was, this is one of the most basic ways we care for ourselves. And I get a lot of people who come to see me and say, I really don't need a dietitian. When I was diagnosed, I threw out my salt shaker. I'm good. But the reality is, to get under that 1500 milligrams, it's more than just avoiding the salt. You really have to be label aware and conscious of everything you eat and drink.
Yeah, absolutely. I think that makes perfect sense. Thank you so much.
You're welcome. Thanks for having me.
So, Dr. Rosenblum, thank you so much for sharing all of that really important information. I think that a lot of the patients who are joining in, or even family members of people that are joining in, have learned at least a little bit of the nuances and some of the understanding behind the medications that we use for both of these conditions. I will tell you that as a cardiologist that sort of was around during all of the like SGLT2 inhibitor data, it has been a very exciting time. And it seems like this, just like you talked about the valsartan sacubitril medication, Entresto is the brand name, being one of the big game changers in heart failure and in cardiology, because it treats all of these multiple types of heart failure. It seems like SGLT2 inhibitors are definitely taking the place of a lot of other medications. And it's a very exciting time, I think, for cardiologists, because there's so many more medications that we can use. So can you tell me a little bit more about your comfort level? Like, what should cardiologists that may not have, or even patients whose doctors are thinking about starting this for the first time, what should they be looking out for?
Yeah, thanks for the great question. So SGLT2 inhibitors are actually very well tolerated in most patients. And what's nice about them is that, kind of on top of the other therapies that we talked about for heart failure, like beta blockers and ACE inhibitors, or an ARB or Entresto, we can really add SGLT2 inhibitors to those therapies, and there's additional benefits with using the SGLT2 inhibitors because they work through different mechanisms. And SGLT2 inhibitors in general cause less effects on lowering blood pressure. So where patients may become dizzy with some of those other medications, they really don't cause those effects. And so from my personal experience, I think that they've been very well tolerated. Some of the main side effects that I've noticed and that have been reported by the studies and by, after the approval of SGLT2 inhibitors, are mostly related to kind of the increased fluid removal, so the diuresis, that can lead to some dehydration. There are also people have been seen to have yeast infections and also urinary tract infections. Usually they're very mild, but sometimes we need to stop the medications for those reasons. And then in rare circumstances, SGLT2 inhibitors can cause like a type of diabetic ketoacidosis, and that is an issue that requires hospitalization. That's really the most dangerous concern with SGLT2 inhibitors, although it's very rare. But in general, I think using SGLT2 inhibitors, I try to add them on to almost all of my patients with heart failure, because I think they're a great medication and pretty well tolerated.
Yeah, I mean, I think it's great as a cardiologist to be able to get patients who are on a loop diuretic like Lasix or torsemide or something like that, and maybe a low dose, and then be able to get them off of that drug and get them on medications like the SGLT2 inhibitors that have some sort of diuretic effect. And so I think it's really nice to be able to use the data and be able to use all of the evidence to take care of our patients without just throwing medications for symptom management. This kind of solves both of those. I also think you raised a really good point about it being very well tolerated. So it's something that seems like it's very simple to use, but I do think that there is a little bit of a lag in the medical community, not so much in cardiologists. I feel like cardiologists are very excited about this drug class, like you and I are. But I think in primary care settings and endocrinology settings even, I think it's a little bit difficult for patients to get access to the medication because their doctor just doesn't want to change what they're on already, even if it's not the best thing for their cardiovascular care. So I would say for the people who are watching, or for the people who are watching who also have loved ones, if you don't yourself, who have heart failure or diabetes or both, that this is something that you should probably talk to your doctors about. It's not for everybody, obviously, but the benefits in terms of diabetes, heart failure, and kidney disease has been pretty well studied at this point. And it's one of those things that we want people to know about so you can empower yourselves to ask for the right medications. But I think, like anything else, the most important thing is what you can do for yourself. So dietary restrictions, fluid, sodium, and lifestyle modifications, weighing yourself, going to the doctor, doing all of the other things, getting all of the preventative measures that you need to get, is probably going to be the best thing for anyone. What do you think, Dr. Rosenblum?
Yeah, I agree.
So with that, I think we'll conclude. Obviously, we covered a lot of information. We've had several other topics, specifically focusing on just heart failure and then just on diabetes, that are listed on our website, and that will be shared with you. But if you have any other questions, we will share our contact information. And thank you so much for joining us. I hope everybody has a really healthy, safe, happy Heart Month season. And thanks for tuning in.